everyone. Thank you so very much for joining us today with Dr. Paganoni. We're so thankful that she's here to talk with us and enjoy the few minutes that she has available so that we can just lay it out there and have those discussions. So I'm just kind of giving everybody just a quick second to get started. Feel free to share your cameras. And at some point, what we're going to do today is basically talk about Q&A. You got questions particularly. Dr. Paganoni is here to answer those questions. And then what we want to do is to be able to set up the opportunity for us to come back on a more regular basis and have other greater in-depth conversations. Does that sound good to everybody? Yep. All right. That's what I like to hear. Okay, well, without further ado, Dr. Sabrina Paganoni, please come on and tell us all the things that you know of where we are in science and research.
Yes, thank you. First of all, I really love the work that the SPF does and always love meeting with all of you and many of you I met in person or corresponded with. So really great to reconnect. And you know, I was talking with Norma and Hank and others, and you know, I thought that it might be good to just rather than me giving a presentation, just I really want to hear from you and see what your questions are. And the timing is good, I feel, because we just had a fantastic conference that basically summarized the state of things in PLS. And as you may know, the SPF kindly posted the video online with all the highlights from all the talks at the conference, all the slides, and actually we are working on a summary paper that I literally have next to me. I'm hoping to finish that over the next few days, and our postdoctoral fellow, Dr. Shiroko, led that, and we contributions from all the speakers, and that would be a nice summary that we can also post and share with all of you. So again, my goal is to continue to make research news more widely available, as all of us have been trying to do in collaboration with the SPF for the last few years. But wanted this to be an opportunity in case some of you may have seen watched the recording of the conference. The conference was happened in Montreal in December. And it was the third international conference on PLS. So it was really kind of, a great summary of everything that's out there. We had over 100 people attend in person from around the globe, and they provided updates on everything about PLS that's in the literature. So, with that in mind, I don't know if you have any questions about the conference or next steps or any of the material that was presented.
Okay, everybody, don't rush to raise your hand, but here's your opportunity if you had any thoughts or any questions concerning anything regarding that conference. And if that is not where you are right now and asking particularly about the conference, do you have a question for Dr. Paganoni? Go ahead, Kevin. I see your hand raised.
Hi. I'm wondering if there is a difference that's been observed in spasticity with PLS patients versus spasticity in other conditions.
Yeah, that's
the question comes from PTs not having any idea what to do to help with it.
Right. No, that's a great point. So I would say that, spasticity as a term has the same anatomical and sort of biological mechanisms whenever, regardless of the disease or the condition when it happens. So it is a particular state of the muscles being tight as a response to a neurological process. And so that could happen in PLS, it can happen in HSP, it can happen in other disease areas, and maybe that may be part of the confusion. For example, people with stroke or multiple sclerosis, MS, they can also have spasticity. So your question is a good one. Is there anything specific or different about the spasticity that one person with PLS experiences compared to other people that may have spasticity, but may have that due to a different disease. And so, I mean, I would say that, again, the anatomical and biological mechanisms are the same. So from that point of view, there's no difference. What I think is a characteristic of PLS compared to other conditions is that the spasticity is one of the predominant features of it. It really kind of predominates. So for example, if you have a stroke, let's say, you may have other things in addition to the spasticity. And in PLS, kind of the spasticity is sort of like a driver or many things, a kind of a very predominant symptom that affects other things and causes other problems as well. So that's what I would say. Also in PLS, and everyone is different, but it can affect different areas of the body. In other words, let's say that if you have a stroke, again, going with that example, and that stroke only affects the right leg, for example, the spasticity will only be in that right leg as a result of the stroke. In PLS, and again, everyone can have a different, presentation or experience, but generally speaking, on average, people with PLS, if they have spasticity, they'll have it on both sides, and they can have it in different areas of the body. So again, it's not that it's completely different from another disease area, but it's more that it's kind of a very predominant or substantial issue. And again, it can be affecting different areas. Now, I guess your question, it's good that you provided the background, why are you asking, right? You're asking because you want to treat it, right? You want to work with your PT or with your physicians to try to reduce spasticity or help it, right? And so I feel like the medications and the PT interventions for spasticity are sort of the same in PLS as in other disease areas. So I think your PT could feel comfortable kind of treating things the same way. However, again, because in PLS, it's a little bit more marked. It's a characteristic presentation. You may have to use more than one medication or more than one tool, and that's where the experience comes in. In other words, you may need somebody who can maybe connect with an experienced neuro PT who has done this for other patients, and so can really get most out of it. Because if you just kind of, if you don't have experience and you're sort of hesitant, maybe you don't treat things to the same extent because you don't feel comfortable, and then you undertreat. Because in PLS, spasticity needs to be more marked than in other diseases. I don't know if that's helpful, but I wanted to provide kind of some quick background information. Yeah.
That is very good, Dr. Paganoni. Thank you so very much. You have Melissa over in the chat box. Do you see this? There's a couple other questions down through there. Melissa,
Yeah.
you feel free to come on and ask the question if you
Yeah.
would like to, or she can pick it up and just go from there. Go ahead, doctor.
Okay. So the first one I see is, what is whole exome testing? And the reason this was asked is because some people can have genetic testing as part of their regular clinic experience, but then at the conference, it was mentioned that some forms of genetic testing, like whole exome testing, are done as part of the research studies. And so again, trying to understand kind of clinic-based genetic testing as opposed to research-based genetic testing. So that's a good question. So first of all, the clinic-based research testing is done in something called CLIA certified labs. What does that mean? Those are labs that are certified to provide clinical grade results. So, anytime that you go to your primary care physician or to any specialty physician, whenever you go to a hospital and they measure, blood counts, blood sugars, electrolytes, or anything, or genetic testing, everything is done in clinic grade labs. And that's the way things go, again, because they are, set to report things in a certain way and only report things that essentially, we are well defined. So for example, the panels that look at genetic testing for HSP or ALS or PLS or any other disease, they include a certain number of genes that we are sure, or we know something about, that, we know that they cause that particular disease, whether it's HSP or ALS or something else. And so you get the return of results in your clinic is about the specific set of genes. In this case, I think, Melissa, you mentioned an ALS2 gene that was detected in the clinic. And so it's basically a yes or no answer. There are some technical caveats, but most of the times it's a yes or no answer on a discrete number of genes that are well known and well characterized. Now, when we do research, for example, as part of the natural history study or as part of other studies that you may be familiar with, whether it's the CDC registry or another natural history study. I know some of you participated, have told me in different, large data collections. So the testing is not limited to what we know is clinically meaningful or what we know is sort of CLIA certified, meaning that we can do in the clinic, but it also includes things that are a little bit more exploratory. I mean, that's part of the research itself, right? And so they collect, when they measure, when they do the genetic testing, they measure more than the sort of the standard or well-defined genes that we know cause disease. They test broader for research purposes because ultimately we want to learn more. Maybe there are some genes that have not been described yet, or maybe there are some variants in the genetic code in the DNA that can affect the way people present. So for example, we know that no two people with PLS look the same, right? And so why is that? Because maybe in addition to the well-characterized genes, there are some variants that can change the course of the disease so that somebody will have a slower course or somebody will have a different presentation starting, for example, in the legs as opposed to the face or the speech area, right?
Yeah.
So those are research grade questions that can be answered with that type of testing. So that's why they're not exactly the same. I don't know if that answers your questions. Oh, Norma, you're muted.
I apologize. I was there talking about the next question, Dr. Paganoni. Bill
Okay.
Bishop asks, has been any groups created to compile information on PLS patients, areas they grew up in, career types, et cetera, to possibly identify possible environmental similarities that might be a part of the cause? I've seen studies like this for ALS.
Yeah.
Yeah, no, you're exactly right. So yes, so there are many groups that are, as you said, compiling information, and that's what we call a registry or register. In fact, at the conference, many were presented. That was one of the points of the conference, to bring all the different registries or groups from around the globe that do this type of work. And ultimately, we want to aggregate and compile all the data together, right? So that we have more strength in numbers. And so specifically at the conference, again, all the main groups participated. There is a large natural history study, which is, a way to compile characteristics on everyone where people grew up, environmental exposures and things like that. That's led by Columbia University. I believe you had Dr. Mitsumoto and Dr. Lee participate or will participate also. I know I'm in contact with them as well. They presented, and that's, one of the registries that are available in the US. There's more registries. That's the CREATE consortium that also has a lot of biomarkers associated with that. That's led by Dr. Ben Attar at the University of Miami. There is the, I think it's called JETCALS, the Japanese registry. They're doing great work there. Then some European countries have PLS registries, and I hope I'm not missing anyone, but I believe that those are in Italy, the Netherlands, the UK, and Ireland. Those are pretty large registries. At least those are the biggest ones, and they are all being aggregated through a European effort called Precision. And so again, there are definitely those efforts, and they're being aggregated as we speak.
Well, that is interesting, Dr. Paganoni. So how many people would you estimate that are actually worldwide that have PLS? You named a bunch of registries, and some of those are large registries.
Right.
How many people do you think there is?
So I'm not that good at doing math, especially on a live webinar on the spot, but so it has been estimated that people with PLS make up essentially, depending on the different estimates, and again there's some variation in the estimates, but about 2% or between 2 and 4% of the entire motor neuron disease group. And so if you do the math, basically I think that it comes down to basically 1,000 to 2,000 people in the US. And then, I mean, I guess we would have to do the math for each country, but more or less, that's kind of the estimate. So it's 2 to 4% of all people that have a form of motor neuron disease.
Hey. Interesting. That is so interesting. Okay, so another question over here. I have bulbar. So in PLS, can it remain only as affecting the bulbar?
It's possible, yes. There are some people, both in PLS and in ALS, I've seen a few people that remain with that characteristic presentation that can be called bulbar palsy in ALS or again, bulbar PLS. It's hard to predict, in general, I would say, many forms of PLS or ALS tend to progress over time. However, there are forms that remain restricted or that progress very, very slowly over, many, many years. So it depends, again, on everyone is different, but that is technically possible.
Do you know anyone with PLS that use any current ALS drugs with success? Because PLS is slow, will it make a difference?
Yeah, that I think is still a dilemma, and we don't fully know the answer. So on the one hand, we know that PLS and ALS progress at very different rates. I mean, this has been demonstrated actually by many of these registries, a lot of published data there. So there's no question that the rate of progression and also the clinical characteristics are different. At the same time, though, there's also some evidence that PLS and ALS may share at least some of the mechanisms that cause disease. In other words, they are at the two ends of the spectrum where PLS is slower and ALS is faster, but there are some common mechanisms. And so for that reason, some people have argued about, giving access, basically using riluzole or edaravone for people with PLS. I will say there is no consensus. Technically speaking, these drugs are approved for ALS, not for PLS. They were never formally tested in PLS. And so the clinical guidelines don't recommend to prescribe these drugs to people living with PLS. And in my experience, most people don't use them. I mean, the question is it in theory possible that it may do something good in PLS? Again, unfortunately, we don't have any data, but that's basically the state of the situation. Now, the tricky part here is that actually, when we looked at our retrospective registry a few years ago, people living with PLS, if you use the same outcome measures that are used, so if you chart the course of disease progression using the ALS scales, so in ALS, everyone is kind of measured using a certain scale called ALS-FRSR, and on average, and again, this is, approximate because all of these are averages and don't necessarily, don't necessarily represent individual experiences. But when you look at everyone, at the entire population on average, people living with PLS progress on that scale at a rate of about 1 point per month. And when we did the registry study, people with PLS, and we looked at a large number of people with PLS, about 250, on that scale, they progressed at 1.5 points per year. So, that basically the same difference that you see in an ALS patient in about a month, the same type of change, you'll need 1 year instead to see that in PLS. And so, so that's how, that means that PLS is obviously substantially much slower than ALS. Why am I saying this right now? I'm saying this because when you look at the ALS trials, the clinical trials that were done to test these drugs, riluzole, edaravone, other drugs, in ALS, if you included people with PLS in those trials and just use the regular ALS scale, you wouldn't be able to see any difference in PLS, simply because for people with PLS, you would need to follow them for 5 years in the trial to see the same difference. So it's not like, that's why it was never tested, and that's why we're trying to develop PLS specific scales or biomarkers, because until we do that, it's very hard to tell if an ALS drug works in a person with PLS, because, we would have to do trials that are, 5 years long, and that's just not feasible. I don't know if, I know it's a hard concept, but I don't know if,
Well, but let me ask you this though, Dr. Paganoni, is that if you've got this medication that's working for people with ALS, and I know that's a hyper speed, disease, but yet you've got people on the screen, what you're missing in some of your formularies is that, the actual contact with the person. That person may actually feel something different. It may slow a progression or help them that maybe can't be captured clinically, but yet maybe some of these folks are at the point where they're willing to try that medication. So
again, I understand. No, totally. I understand that people are willing to try, and so I don't disagree with that. What I'm trying to say is that even so, that the drugs that are available for ALS, so there are in the United States, there are 3 drugs that are available for ALS.
okay,
2 are available for all forms of ALS. They're called Riluzole and Edaravone.
okay,
Those drugs have some effects, but very modest, to the point that even people with ALS do not experience any difference.
yeah, I can see that though, because their disease is in hyper mode, so it's coming on to them faster than the medication can fix it,
That's
help it, so to
yeah.
speak.
Yeah, no, that's possible. But again, I feel like also the effect of the drug is not that much that somebody feels
I understand.
better,
Yeah.
and so I think it would be hard to say, well, somebody can really tell a difference on an individual basis, whether they have
Yeah.
ALS or PLS. Now, obviously, on a longer time frame, one could say, well, if I didn't get the drug, I would be a little bit more progressed than if I didn't. And again, I'm not saying
Yeah,
that's not
right.
possible, but that's never been tested. Yeah.
Yeah, maybe what we need to do is look at a proposal that might allow for there to be a very controlled study for us to test that for those.
Well, the
Interesting.
whole point of the conference was, how do we get to a clinical trial for PLS? So I very much agree with your goal. That the reason actually we even did the conference in the first place is to try to find ways to do exactly that, to come together and finally move towards trials.
That is wonderful, and I appreciate all that work. So we have a question that says, I was watching some of the conference and noticed that ataxia and neuropathy are not PLS. How can I go about getting a diagnosis? I had all genetic testing included.
Yeah, so there's a couple of things. I think that there are 2 parts in your question. So there are some features, some clinical features, such as ataxia or neuropathy, that are generally not present in PLS. And sometimes when they're present, they could indicate something else. So for example, there are some forms of HSP, not all forms of HSP, but some forms of HSP that can have those features. Or there are some other neurological diseases that can have those features. So I think the first step is to, again, talk to your physician and trying to understand, is your presentation consistent with PLS, or do you have other symptoms that will give us clues that maybe there's something else? The genetic testing is important, absolutely, but I do want to keep in the back of our minds that sometimes genetic testing is not the only solution, because people could have negative genetic testing and still have a disease, whether it's PLS or HSP or other things. Not all these diseases run in families. And so the genetic testing is just one piece of the puzzle. And then there's, again, a lot of other tests that need to be taken into consideration. And I don't know if I'm addressing your question, but it's unfortunately, we still have a lot to learn about genetic, the genetic underpinning of the disease, but also the different clinical presentations that sometimes are a little tricky.
Thank you so much, Dr. Paganoni. I appreciate that. Patrice Gorup is over here in the waiting room ready to ask a question. So go ahead, Patrice.
Yeah, Dr. Paganoni, thanks for being here. I had a question about white matter. I don't know where I came across it, but there was some discussion of maybe difference in white matter in MRIs for PLS patients. And that was one of the things my neurologist noted when I was trying to get diagnosed, although it was early days for me, and she concluded that there was nothing wrong with me, which I said, oh, yes, there is. But anyway, your
Yeah.
thoughts on that?
Yeah, absolutely. So first of all, the keynote talk at the PLS conference was on imaging, MRIs and PET scans. And the reason we selected a talk on neuroimaging as the kind of the keynote address for the conference is exactly because there's more to learn from imaging. And I think that we're still trying to learn, and definitely there's a lot of promise there. In fact, Norma, if you want, I mean, feel free to invite, Dr. Bidu is the world's expert on everything related to neuroimaging, especially in PLS. I mean, I gave a fantastic talk, and the short summary of the talk will also be part of the paper that I'm mentioning. But essentially, there are people like Dr. Bid and others who are doing great work on trying to figure out the imaging MRI or other modalities, MRI features of PLS. So because PLS is a disease that sort of has a kind of slow and insidious onset, that's why sometimes, it can be tricky to even diagnose, right? Because there isn't just a test that you can, you just send a blood test or something else and you see it. Because the disease starts and develops so slowly and, is also slowly progressing. So over the course of many years, it can have a few features that can be picked up by some more advanced contemporary imaging techniques, such as more advanced MRI or PET scans, which is a different test. And so over time, these changes can accumulate. And so one can see some changes, for example, in the white matter tracts, and they are subtle. So I want to be clear, there isn't a test like, let's say, for example, if you have a stroke, it's sort of easy to pick it up by MRI. Instead, in PLS or other diseases of this type, they're more subtle. So they're more research-based, but the signatures are there. So again, you have to look at them more with the eyes of a researcher more than regular clinical MRIs, almost similar to the discussion we just had about genetics, right? There are some things that are clear and categorized and, you have clinical tests, but then when you do the same test, whether it's genetics or imaging test, and you do it at a research level, you can use it to look for more clues. And so that was kind of the extent of the talk, where Dr. Bid and others are leading these large studies where they're really looking with research grade machines at the MRIs of different people with PLS and other conditions as well, and are starting to see some of these changes, especially as the disease continues over time. So sometimes it's particularly difficult to identify them at the beginning of the disease, but as time goes by, one can do it. And that's why they have these imaging studies going on to really try to understand it better.
I'm going to participate in June with Dr. Fink's MRI study.
Perfect. That's great.
And my wife is going as a control, I believe.
I had to tell you, actually, thank you to both of you and your wife as well. I had to tell you the one of the difficult parts of these type of research studies is to find controls. And I will say that it's wonderful that both you and your wife want to participate, because we need to be able to compare things. And so that's, 2 for 1 is fantastic, really generous contribution. Thank you.
If I may, to comment on the earlier topic of causes, I found it interesting that the small numbers, there's 3 people, myself included, that live within a 5-mile radius that have PLS. And we have very sandy soil. I'm thinking about the water, and there's a EPA Superfund site that's kind of upstream from us. I don't know if that's, but I find it interesting that we're so close together.
Yeah. Are you in Michigan?
No, I'm in Nebraska.
Okay. Yeah, I was asking because there's some colleagues from the University of Michigan are doing a study on something called the exposomes, and they coined this term. Basically, exposome is sort of the totality of exposures that a person has. So all of us are exposed to something like, pollution or pesticides or whatever. And so they're studying that. So it's, I think, mostly for ALS, but I would not be surprised if they included also people with PLS.
Dr.
Well, it's a agricultural area too, and very sandy soil, so the water moves through the soil.
Yeah.
Anyway, sorry, Norma.
Hey, no, Patrice, I think you're really onto something. I think there's a lot of things that they're now finding and discovering, a lot of food additives, a lot of things that are happening, that may be something that's triggering your health to not be at its optimum, and maybe even kind of injecting a little tiny bit of poison every day that's causing the spasticity to get worse. I don't know. Those are things and conversations that I think we all want to continue to have. And I would love to bring some of those folks on to an SPF Talks and us listen to them directly. I think that would be wonderful. I know, Dr. Paganoni, you had dedicated 30 minutes to us today, and we're up on that time frame. So I think unless you've got some parting words for us, then
Well, I mean, since I see that there are many questions, I mean, initially when, thank you so much, Hank, for reaching out to me. We were not, I mean, I wasn't sure, will people have questions, but I see many questions. So let's do this again.
yes, let's
it
do this
soon.
again. And what I'd like to do is capture these questions and
Yeah.
perhaps maybe then send them to you. And when you get a chance, you can work on answering those. And then we
Fantastic.
can blast that out to everybody that is on this call. And then
Absolutely.
let's get back together and have another conversation. Are you guys all good with that? My crowd,
Wonderful.
yeah, thumbs up, everybody, yay.
This is a great crowd. Thank you. Looking forward to seeing you again.
Thank
Okay,
you,
thank you so
Dr.
much.
Paganoni. We appreciate you very much, and you have a great weekend.
Thank you. Bye-bye.
Thank you.